animal reservoirs of disease to our doorsteps, hundreds of millions of humans and host animals living cheek by jowl, and a planet-wide, just-in-time supply chain delivering everything from electronics and auto parts to life-saving medicines, without which the most advanced hospitals cease to function. Has a century's worth of scientific advances left us better prepared to deal with such a cataclysm? Unfortunately, as we describe in Chapter 19, not really. In plain fact, everything we wrote in the first edition of Deadliest Enemy, the analysis, the priorities, the proactive recommendations, remains true and relevant. We take no satisfaction in having been right, but the fact is, we've had fair warning. Let's look at the realities. Trying to stop an influenza-like transmission such as COVID-19 is like trying to stop the wind. At most, its spread was slowed by the near-draconian lockdown the Chinese government was able to impose on hundreds of millions of its citizens, as well as efforts by other countries such as South Korea and Singapore to identify infected people and anyone they might have been in contact with, an effort that was sorely lacking in the United States. The only way the spread could have been curtailed was with an effective vaccine, which did not exist. Starting from scratch on such an undertaking requires many months, or even years. In any pandemic, effective leadership is critical, and the first responsibility of the president, or the head of any nation, is to offer accurate and up-to-date information, provided by public health experts, not agenda-oriented political operatives. It is far better to say we don't know something, but that we're working on finding out, than to offer happy talk that may be contradicted by the next news cycle. If the president sacrifices his credibility, the public will not know where to turn. However, studies have repeatedly shown if the public is given honest, forthright information, panic almost never ensues, and we all learn to pull together. CIDRAP, the Center for Infectious Disease Research and Policy at the University of Minnesota, stated on January 20th, 2020 that COVID-19 would cause a pandemic based on the clear transmission characteristics of the virus. Why did it take the World Health Organization, WHO, until March 11th to declare a global pandemic? We believe this led many leaders and organizations into a sense of complacency that there was still a good chance of containing the virus, and became an unfortunate and unnecessary distraction from the vital planning process of how to mitigate and live with it. That kind of confusion and debate should make us realize we need a new and more effective way of evaluating when the world is at risk from a new deadly enemy. The first critical question we must confront is, how did we get into this crisis? As with most disasters, it is a convergence of several factors. In the nearly 2 decades since SARS, the world has become far more critically dependent on China for its manufacturing resources. We live in a just-in-time manufacturing, supply chain, and delivery mode today. It's one thing if we can't get the latest televisions or smartphones when we want them because a factory in Hubei or Guangdong province is shut down by a disease outbreak. It's quite another if we can't obtain the life-saving medicines that stock hospital crash carts and maintain the day-to-day well-being of the millions with chronic diseases or health conditions, or can't get the vital personal protective equipment, PPE, that protects healthcare workers in direct contact with COVID-19 stricken patients. Consider this sobering statistic. Shortly before the 2009 H1N1 pandemic, CIDRAP undertook a national survey of hospital pharmacists and intensive care and emergency department doctors, as we detailed in Chapter 18. The update of that survey identified more than 150 critical life-saving drugs for all types of diseases frequently used in the United States, without which many patients would die within hours. All of them are generic, and many, or their active pharmaceutical ingredients, are manufactured primarily in China or India. At the beginning of the COVID-19 outbreak, 63 were already unavailable to pharmacies on short notice or on shortage status under normal conditions. Just one example of how vulnerable we are. And as illness and quarantines idle Chinese factories and disrupt or shut down